Now we would start with the keratoconus. It is one of the most important topic in cornea. Many of the questions in your postgraduate medical entrance examination has come from this topic. Keratoconus and LASIK and corneal ulcer. If you want me to tell you the three most important topics in cornea, then these are. So first of all, I would give you a question. Then we would see what is keratoconus, how it is treated, and other important points for it. So question is, which of the following is not seen in keratoconus? Option A, Fleischer ring. Option B, central thinning of cornea. Option C, hypermetropic refractive error. Option D, Descemet membrane may rupture. So now we come to the keratoconus. Then we would again see what should be the answer of this question. So how a normal patient presents? Basically, a keratoconus patient is a young male with constantly changing power of glasses with myopia and high cylinder. Means, let's say a second-year-old student, a 21-year age MBBS student, came to the eye OPD, says that, sir, my number is always changing. Earlier my cylindrical power was -3, now it is -3.5, plus my spherical power, that is -4 or -5. So every time he comes, there is a change in power. So we did the dilated refraction, we did the topography, and then we diagnosed, yes, that he has keratoconus. Few important signs in keratoconus that you should know. The sign 1 is Munson sign. Sign 2 is oil droplet reflex on the retinoscopy. Sign 3 is hydrops in later stages. Sign 4 is scissor reflex that is seen in retinoscopy. Enlarged corneal nerves, Rizzotti sign, and the Fleischer ring. I would explain what these signs mean. First of all, Munson sign. Basically, when the patient looks downwards. Can you see in the picture? When the patient looks downwards, there is a bulging of eyelid. This is called Munson sign. The second is oil droplet reflex. When we give the power of glasses, then we do the retinoscopy. In the retinoscopy, there is a yellowish round reflex that comes, that is called the eye oil droplet reflex. Plus, as I have told you earlier, these patients have cylindrical power. So when we move the retinoscope from, let's say, right to left, then this doesn't go like this only. This does, the retinoscopy reflex goes like this. So this is called scissor reflex. Then the hydrops. What is hydrops? I told you that there are 5 layers in the cornea. The innermost layer is endothelium, and above this is Descemet membrane. Descemet membrane is a very thick membrane that I have told you. But in cases of keratoconus, there is a thinning of cornea. So this Descemet membrane can rupture, and this aqueous humor can seep down from the anterior chamber to inside the cornea. This is called hydrops. Then the enlarged corneal nerves. This is a misnomer. They are not enlarged corneal nerves, but because of thinning of cornea, these nerves look more prominent. Okay. Then the important sign, that is the Rizzotti sign. You should know what is the Rizzotti sign. Can you see in this picture? Now we are showing the light from the temporal side. Normally what happens, that this light is there up to the half of your nasal depth. But in keratoconus patients, since the eye is a bit conical, that's why this light can pass it, and more than 2/3 of nasal side is illuminated. Can you see in this picture that more than 2/3 of the nasal side is illuminated? This is called Rizzotti sign, and this is because of deep anterior chamber, because your eye is now conical, so the light can pass throughout. But in a normal cornea, when it is a spherical cornea, then light cannot pass through. Most important investigation in keratoconus is keratometry. What is keratometry? Keratometry means knowing the power of various curvatures of cornea. Okay, so I told you there is an anterior surface and there is a posterior surface. So in keratoconus, there are differences in both anterior and posterior surface of the cornea. Normal, the curvature of cornea is around 43 to 44 diopter, but in a conical cornea, can you see this is steep? So in steep corneas, what happens is this curvature increases. So if normal, I am having 43 diopter or 44 diopter cornea, a keratoconus patient would have around 47, 48 or even more that of corneal curvature. So this is called steep cornea. Plus, whenever there is a cornea, there is a normal pattern. There is a vertical pattern or a horizontal pattern. But I told you the cylindrical is high in keratoconus, so there is a bow tie pattern. Bow tie means we make there is a coat and there is a, like this the tie pattern. So normally the pattern is like this, but in keratoconus this pattern goes like this. This is called bow tie pattern. Another thing that is comes in the keratometry is that from the keratometry or corneal curvature map, we can know what is the thickness of cornea at various places. I told you the thickness of cornea is least in the center part, that is the 530 to 550 micrometer that I told you when I told you about the corneal anatomy. But in a keratoconus patient, this corneal thickness decreases, and this thickness decreases most commonly in the central or paracentral part. Okay, so the cornea in a keratoconus patient is a thin cornea. So three most important things that you should know about the keratometry in keratoconus patients is steep cornea, that is the increased corneal curvature, the bow tie pattern, and the paracentral thinning. So now we come to the question again that I gave you. Which of the following is not seen in keratoconus? Fissure ring is seen. Yes, it is seen. It is a iron deposition ring. Central thinning of cornea. Yes, there is a central thinning of cornea. More specifically, a paracentral thinning of cornea. C. Hypermetropic refractive error. This is wrong. That the refractive error here is myopic and high cylinder. And fourth, Descemet's membrane may rupture. Yes, Descemet membrane may rupture, and that is called hydrops. Okay. Now, can you see here the third pattern? This is called a bow tie pattern. Okay. Can you see the redness in the inferior part, and there is a small oval type of red in the superior part? This is called bow tie pattern. Now we come to the how to treat keratoconus. Now the question is, which of the following is not a treatment modality for keratoconus? Option A, spectacle. Option B, prism. Option C, contact lens. Option D, Intex. Now we would see how to treat keratoconus, then we would come back to this question. Okay. So first thing and the basic thing in medical science is keep it simple. Okay. So if a patient is having myopia, okay, a patient is having high cylinder, okay, then what is the first thing you should do? Give the spectacle. Do a good refraction, then give a spectacle. But sometimes this high cylinder and high myopic glasses, patients are not comfortable. Plus there are some cosmetic problems also. So in these cases, when patient is not comfortable with spectacles, then we can give customized contact lenses to the patient. These are basically used in the keratoconus, and three type of contact lenses can be given. One is a rigid gas permeable, second is the rose K lenses, and third is the Soper lenses. Now please remember that these contact lenses are not soft contact lens that we give to the myopic patients. These have to fit to the corneal design. I told you that cornea is steep here. So we have to make a lens that fits into the cornea. You cannot give a simple lens that slides up and down over your corneal curvature, because here everywhere, every point of cornea is having different curvature. Okay, so the patient won't be comfortable. So rigid gas permeable lens, rose K lens, and Soper lenses are customized contact lenses that are used in keratoconus. Now, the thing is, I told you from my first slide that constantly changing power of glasses. The patient came with high myopia and the constantly changing cylindricals. So, important thing is to halt the progression of this change in number. So, how can we do this? There are few options. The most important for PGME purpose and clinical purpose is collagen cross linking. So what we do, I told you there are 5 layers of cornea. We scrape off the epithelium, okay, then we put riboflavin drops over the cornea, then UVA radiation is put for 30 minutes. This UVA radiation of 370 nanometer is put over the de-epithelialized cornea. So what it happens is, when this UV radiation fell, there becomes bonding between, or collagen bonds between, various layers of cornea, various layers of collagen in the stroma. So let's say there are 10 layers of stroma, then we put UVA radiation, so collagen bonds are formed between various collagen fibers, okay. So this covalent bonds between various collagen fibers, what it gives to the cornea, it makes it stiff. So when there is stiffness in the cornea, then the chances of this constantly changing power are less. This is the basis of collagen cross linking. So anywhere where there is a thinning of cornea, that can be a keratoconus. Also post LASIK, because what happens is LASIK is we have to decrease the thickness of the cornea, or a fungal corneal ulcer or any corneal ulcer, we can do this procedure. So collagen cross linking can be done in keratoconus or anywhere wherever there is a thinning of cornea. Okay. Now can you see these two pictures? The right one and the left one. Can you see two rings? Now these rings are not anterior chamber IOLs. These are the rings, two rings placed in the cornea. So basically what we did is we made a tunnel inside the stroma and we put two rings here. So these two rings made cornea stiff. Okay. What are these called? These are called intacs. Intacs is intracorneal ring segments. Okay. Now let's say there is a hydrops. After hydrops there is scarring of the cornea. All there is the transparency of cornea is gone. Now what we can do? The only thing we can do in a hydrops is a penetrating keratoplasty. What is a penetrating keratoplasty? We remove the diseased cornea and we put a new donor cornea over that. That is called penetrating keratoplasty. Now there are three types of surgery that we can do in a keratoconus patient. One thing that I told you, that let's say there is a hydrops, then we can take whole of the cornea and we can put the new one. That is called penetrating keratoplasty or full thickness keratoplasty. But what is peculiar in keratoconus is that only stroma is involved here. Okay, endothelium and the descendant membrane is normally not involved unless there is a hydrops. So in a country like India, where the availability of cornea is low, and second thing is, when we remove the whole cornea and we put a new total penetrating keratoplasty, the chances of graft failure are there. So to decrease the amount of chances of graft failure, what we do is we remove half of thickness of cornea. Let's say we remove the epithelium and the anterior stroma and we put a new only epithelium and anterior stroma from the donor tissue. So the endothelium of donor tissue is also left and endothelium here is also left. So the chances of graft failure are less in these cases. This is called lamellar keratoplasties. So now you can do whatever type of lamellar keratoplasty. If stroma is gone, you just, because epithelium can regenerate, you don't have to do a epithelial transplant. Only thing that has to be done is either stroma or descent or endothelium. So if stroma is diseased, you took over half of the stroma, put a new one. This is called anterior lamellar therapeutic keratoplasty. If you pull out whole of the stroma, or let's say 2/3 of the stroma, and put a new one over it, that is deep anterior lamellar keratoplasty. If you take out whole of the cornea and put a new one, that is penetrating keratoplasty. So 3 type of keratoplasties that we can do in a keratoconus patient. Now we come to the question that we gave you. Which of the following is not a treatment modality for keratoconus? Now you can solve it in one go. Spectacle, yes, this is the first one. Prism, no, prism cannot be given. Prism is given in squint patients, okay, not in a keratoconus patient. See, contact lens, yes, contact lens can be given, and these are customized contact lenses. And fourth is the intacs. Intacs are the intracorneal ring segments. Now, see this figure. What is this instrument called? This instrument is a placido disc keratoscope. Can you see the circular rings here? So basically, the patient puts chin here, and then after putting the chin, this keratoscope maps the anterior curvature of cornea. So this is a placido disc keratoscope that maps the anterior curvature of cornea. Now, I told you that both anterior and posterior curvature can be involved in keratoconus. So the instruments that basically diagnose it are pentacam and OBSCAN. You don't need to see the and identify pentacam and OBSCAN picture, because these are in various models and normally won't be given in your PGME exam. Option D, that is the confocal microscopy. Confocal microscopy is basically an optical biopsy of cornea. This means that if there are some problems in the stroma, let's say some fungal infection or some dystrophy, then it can basically take a biopsy of cornea, optical biopsy, and tell you where these regions or any degeneration or any deposits are there in the stroma. So that is the confocal microscopy. So this instrument is a placido disc keratoscope. Placido disc keratoscope, pentacam and OBSCAN can be used in a keratoconus. Confocal microscopy is a totally different thing that is used to diagnose any dystrophy or any fungal infection.